To start, I want to review some terms that are important to understand or at least be familiar with in order to read a lot of these articles and understand what they're talking about with all these different tests and which ones are better and which ones are worse. So, validity is how good a test is at separating out the people who have COVID 19 from the people who don't. And reliability is how much that test will get the same result over and over again if you keep using it. So a test could be reliable but invalid. So, like if a test repeatedly will label someone as positive for COVID 19 when they really don't have it, but it gives you the same result every single time, that would be reliable but invalid. A gold standard is the best available test. So with COVID 19, we don't really have clear gold standards yet because it's such a new virus and all of the tests are new. But for most diseases, we have an older test, which is known to be really good. But a lot of the time, the gold standard is a test that is either expensive or has other harms, such as radiation. So, a gold standard test is something that usually isn't used on a big scale for a population, but it's something that we can compare a new test to when we're trying to talk about how good it is. Sensitivity and specificity you hear a lot about, and it's really important to understand that these terms are derived from using the test in a research setting where you already know 100% for sure if all of the people that you're testing have the virus or don't have the virus. For example, let's say if a new company just invented a rapid COVID 19 test and they want to try it out, and they get volunteers who are already tested by the San Francisco Department of Public Health with the more established test. So all of the people joining in this study already have a test result. So they already have been confirmed to be positive for COVID 19 or negative for COVID 19. And then all of those participants in the study get tested again with the new rapid test. So if you take a group of 100 people who already tested positive for COVID 19, and then you test them with your new rapid test you're trying out, and 90%, 90 out of those 100 people who are known to be positive get a positive result on the rapid test. That means it has a sensitivity of 90%. And specificity is if you take a group of 100 people that were confirmed not to have COVID 19 infection and you test all of them. If 97 of the 100 test negative, meaning they get a correct negative result, then the specificity of the rapid test would be 97%. So it's really important to understand that these two terms are for kind of fake settings where you already know if someone has the disease or doesn't have the disease. Likelihood ratios are based only on sensitivity and specificity, but they're another way that clinicians sometimes look at to help either rule in or rule out a diagnosis. Predictive values, on the other hand, take into account the prevalence of the disease in the population. In a situation where you have a real life group of people and you get a test result. So let's say you go get tested and your result comes back positive and you want to know, okay, my result is positive. What does that mean? It's predictive values that give you the answer to that question, not sensitivity and specificity. So the positive predictive value is the proportion with the positive test who actually have the disease. And the negative predictive value is the proportion with a negative test result who don't really have the disease. I realize this slide looks a little busy, but this is how we often teach these terms in population health. If you look on the left, these box diagrams are a way of looking at sensitivity and specificity and how we come up with those numbers for a test. On this side of the box, we have disease. So the positive is the people who actually have the disease in real life, and the negative is the people who do not have the disease. But then on this side, we have the test result. So if someone actually does have the disease and their test result is positive, that makes them a true positive. If someone actually does have the disease, but they test negative with the test, that means they're a false negative. If someone does not have the disease, but they get a positive test result, then they're a false positive. And if someone does not have the disease and they test negative, then they're a true negative. So ideally, we would want everyone that we test to be either true positives or true negatives. But unfortunately, in real life, it never really works out like that. Every test will have some people incorrectly labeled as being positive, your false positives, and every test will incorrectly label some people as negatives, your false negatives. Sensitivity is the people who are the true positives, so the people the test correctly labeled as being positive for the disease, divided by all of the people who have the disease for real. So you can see it's this light blue area. Specificity is your true negatives, the people who test negative and who really do not have the disease, divided by all of the people without the disease, so the white vertical box. This is different from predictive values because instead of being in a research type setting where we already know everyone who has COVID-19 and everyone who does not have COVID-19 at the beginning, this is more like a real situation where you're starting out knowing the patient's test result. So you know if your test result was positive or negative, but you don't know at the beginning whether you actually have the disease or not. So predictive values are much more like the real life situation of using tests. Positive predictive value is the people who actually have the disease who tested positive, divided by all of the people who tested positive. Negative predictive value is the people who tested negative who actually are negative, divided by all of the people who got a negative test result. As an example, to show why positive predictive values and negative predictive values are really important in real life as we're rolling out these new antibody tests and trying to interpret what the results mean if you test positive or if you test negative. In the United States, the prevalence of COVID-19 is estimated to be about 5% right now. So if you take a test and you get a positive result, assuming that that test has a 95% sensitivity and specificity, that would mean that you have a positive predictive value of 50%. So positive predictive value is the odds that your test result is a true positive if it's positive. So the odds that you actually have COVID-19 given that you just got a positive test result. So 95% sensitivity and specificity sounds really good, but a positive predictive value of 50% is literally the same as flipping a coin. So if you use a test with a 95% specificity and sensitivity and you get a positive test result, it's a 50-50 chance whether or not you actually have COVID-19 or not. So that's really not helpful at all. The negative predictive value is actually much better. Even with a 95% sensitivity and specificity, that's going to lead to a negative predictive value of 99.7%. So that's much more helpful. That means that false negatives will only be 0.3%. So if you test 1,000 people in the United States with a prevalence of 5% for COVID-19, then you're going to get 3 people who get labeled as being negative for COVID-19, but they actually do have it. It's important to stop to think about the implications with this, given that we're talking about real people in real life, for positive and negative test results and for false positives and false negatives. If someone gets a false negative result, meaning they do actually have COVID-19, but they get a negative result on the antibody test, so they're issued a immunity passport and they go back to work, that could have serious consequences, because if they're a grocery store checker or some other job where they interact with a lot of people, they could be unknowingly spreading COVID-19 because they thought that they didn't have it and they actually did. False positive results also can have a big impact, because if someone tests positive, that may mean that they're not permitted to go back to work, even though they should have been. And when you get a positive result, the public health departments are trying to go and test everyone that that person came in contact with. Contact tracing is a really important part of the public health response to getting COVID-19 under control. And every single time there's a false positive result, a bunch of public health staff are going to identify the contacts of that person and try to track them down and test all those other people. And that can waste a lot of resources chasing down something that wasn't even real in the first place. So if we go back to this again and look at if we have a test that has a sensitivity of 99% and a specificity of 99%, and we're using the same United States prevalence of 5%, that would lead to a positive predictive value of 83.9%. So that means that if you get a positive test result with that test, that means that there's an 83.9% chance that your positive test result means that you actually have it. So that's pretty good. That's pretty helpful information. But still, that's going to give you a false positive rate of 16.1%. There's still going to be a significant amount of people that are going to get a positive test result, even with a test that's almost perfect. And those people are then going to think that they have it, and a lot more resources may be used to test everyone that they've been around trying to track down the infection, even though the test result was actually wrong. The good thing is when you have a test with a sensitivity and specificity of 99% and the prevalence is 5%, the negative predictive value is almost 100%. It's 99.9%. So that means that with the antibody test that we now have and are starting to use, if you test negative, it is very, very likely that your negative result is a true negative result. Meaning that if you test negative for the IgG antibody against COVID-19, we can be pretty confident in saying, okay, your negative test result actually means that you do not have those antibodies. So you are not immune to COVID-19, which is helpful information. If you're interested to learn more about how testing works and how we come up with these numbers, click on the link below and that'll take you to a blog post I wrote with more detailed explanations.